For the first 45 minutes or so, I'm going to talk about an introduction to a case that caused us a small clinical issue. It's an area where we work closely with radiology colleagues. It's something that doesn't come up particularly frequently for us as ICU clinicians, and I think from later discussions is a part of the radiology curriculum and doesn't necessarily come up all that often for our colleagues in radiology. So we thought it would be useful to have a bit of a joint session to discuss and sort of share perspectives. So hopefully, by the end of the session, we should be familiar with criteria for diagnosing death. So I've got a variety of residents at different levels, and it might seem really odd thinking about how we diagnose death, but we'll talk about how and why we do that and when we need to do that. There's another term called ancillary testing, which essentially comes into play where we're unable to diagnose death using our standard procedure, and then when we might want to use it, ancillary testing, and why we might want to do that. And that's where we call on our radiology colleagues for help. After I've spoken about the case, David's going to talk and hopefully show some interesting images of what's involved from the radiology side, because actually from our side it's really useful to know what our colleagues in other specialties are going to do when we ask for certain tests. So David's going to talk a little bit about what the procedure is from the radiology side. And then finally, those of you that have been on intensive care for a little while may be aware that the guidance on how we undertake brainstem death testing has very recently changed at the beginning of the year. I know we showed a video in December of last year, but some of you have changed since then. So this is just kind of reminding you that whenever we get a case of brainstem death, that the guidance for how we diagnose it has changed recently. Okay, so quiz time. We're going to start by activating some prior knowledge and sort of thinking about what you know already about diagnosis of brainstem death. So question 1 of 6. You're ready to go. We're going to start. So brainstem death is diagnosed based on the irreversible cessation of all brain activity, including the brainstem. Yes, everybody's voted. Okay, so it's true. So brainstem death is the irreversible loss of the capacity for consciousness, including the capacity for breathing as well. So you lose all your brain functions, including the brainstem. That was true. Next question. The guidelines for diagnosing brainstem death only apply to adults and not children. Okay, so that's false. So there are specialist guidelines for diagnosing death in children, and they're under the auspices of the Royal College of Paediatrics and Child Health. So we can't use our standard adult guidance. There are specific guidelines for children, but they do exist, and you can diagnose brainstem death in children. What you can't do is that within the first 28 days, under 34 weeks, you can't confidently make that diagnosis, and that's a new addition to the 2025 guidance. Question 3. So confirmatory tests such as an EEG or cerebral angiography is mandatory to diagnose brainstem death in all cases. Voted very quickly there. Okay, so that's false. Okay, that's true. So as I said, you're essentially testing your brainstem function. So you're testing all of your cranial nerves, and you're testing to see whether somebody has irreversibly lost the ability to breathe. So actually you can do it based on clinical examination, but there have been some slight changes within the latest guidance. So if you don't have 2 eyes and 2 ears, for example, you can't examine the eyes, you can't examine the ears, you then have to look at other forms of testing, like ancillary testing that we're going to be talking about in a little bit. Question 4, let's start. Time of death by neurological criteria is the time of completion of the second set of brainstem tests. True or false? Okay, well done. So that's a change. So those of you that were familiar with the old guidance, it used to be the time of the first set of tests. The new guidance as of January is time of death is the time of the second set of tests, or where the 2 independent doctors undertaking the tests have got all of the information to make that diagnosis. So that's a recent change that I wanted to highlight. And that's the leaderboard. So whoever was being, congratulations. Okay. So let's talk about a case. So this is a 40-year-old gentleman who came into hospital and was found collapsed by his housemates. On arrival in 3D, he had an A2E assessment, as you would expect. He was tolerating an oropharyngeal airway, but not tolerating an eye job. That's 100% on 15 litres. His blood pressure was, as you see it, a bit tachycardic, and his GCS was 5, E1, E2, M2. So I guess for those in the room, what are we going to do with this patient if we're called down and we get those figures there? What sort of things are we thinking? Just shout out.
Concerned about airway, his GCS is 5.
Yeah, I agree with that then. So you've got a GCS of below 8, you might worry about protecting this person's airway.
Much collateral history as to what causes.
You don't know what the cause is, absolutely. So this is a 40-year-old, so you could perhaps make some assumptions that they're previously fitting well, but we don't know that at this stage. But somebody that's young and has come in collapsed with a low GCS and an unprotected airway. So yeah, let's shout out some potential diagnoses that might be going on with this patient.
Drugs and alcohol.
Drugs and alcohol, we see that quite a lot in ED, so yeah.
Hypoglycemia.
Hypoglycemia, yeah. Intracranial hemorrhage, yeah, absolutely. Anything else?
Seizure. Yeah,
So
post-ictal.
It could be post-ictal. So we don't know what's going on with this person. So what are we going to do? A2E, we've done A2E. A2E,
Check the M's, pupils, and room for the CT scanner.
perfect, yeah. So A2E you usually check and treat as you find. So we've got an A problem here, as you said, Ben. So from an ICU point of view, we're going to secure the airway, and I agree, we'll check the glucose, we'll run this person through the scanner and go from there. So I know we're going to go through some imaging later, so I've sort of put the report up there. So CT head on day 1. So when we get somebody with a low GCS that we do a CT head for, what sort of CT are they having?
Non-contrast.
Non-contrast. Why are we doing non-contrast scan? Good. Yeah, but so the reason we're doing a scan at that point, generally, unless this person got a head full of blood, so they need to go to QMC quickly to get that taken out. So the scan showed hyperattenuation of the basilar artery, possible loss of grey white differentiation in the cerebellar hemispheres, no acute hemorrhage. What might that mean?
Ischemic stroke.
Actually. So hyperattenuation, that might be something like a clot sitting there. And what does loss of grey white differential mean to us? Or what could it mean? You can loads of answers, Ben. So anybody else know?
Sort of hypoxic insult that occurs
not immediately, as in some time has passed. Wouldn't necessarily see that initially on a scan.
We sometimes see changes initially. That's usually a fairly bad sign, although all of the guidance that we'll come to later generally highlights that it's probably a fairly bad thing to prognosticate based on the early scan. But you would worry about hypoxic insult. You might worry about some edema as well. But I'll be really honest, I'm not a radiologist, and I'm not used to looking at scans of people that are young and otherwise fitting well. And in older people where there's cerebral atrophy, it's really obvious where you've got the gyro and sulfide. In somebody that's young, I sometimes look at the scans and think that head looks a bit tight, and it's not, which is one of the reasons we have radiology specialists to look at the scans for us. I'm just not used to looking at scans of young people. So you have a CT angiogram on the basis of the hyperattenuation of the basilar artery. So you mentioned ischemic stroke, you'd worry about something like a clot sitting there. So CT angiogram is one way of showing that. Now, if you hadn't done the plain scan to show there wasn't any blood there, because everything contrast and blood both appear white. So that shows the basilar tip thrombosis extending into both posterior cerebral arteries proximally, non-opacification of both superior cerebellar arteries, left occipital lobe, bilateral superior cerebellar infarcts. So he's had a basilar stroke, according to that. What do you do about
He's like young with no past medical history.
that? Okay.
Type of stroke.
I'm not sure, but I know like the guidelines for thrombectomies are you have to have salvageable brain tissue on imaging. I don't know if that counts as being salvageable or not, but if it did, you could speak to Queen's and see.
We spoke to Queen's anyway about that, actually, because he had been involved in trauma. And he, so they can sometimes do thrombectomy as well. He didn't fit the criteria for either of those things.
Probably yes, because it happened like a couple of days ago.
Yeah.
Usually there is like a time limit. So they say from 6 to 12 hours, but it can be extended further if they see that there might be, like some sort of brain hemorrhage. So he's really definitely beyond that timing, because he had the whole thing 3 days ago. So you're really out of that.
So we discussed it with GMC, not for mechanical thrombectomy, and admitted to us here with neuroprotective aims and for neuroprognostication. So when we say neuroprotective aims, again, we've got a variety of people in the room. What do we mean? Because it's a term we often ban around in water. So we want to neuroprotect. So firstly, why are we neuroprotecting? What's the aim of it?
It's secondary assault.
Okay. What secondary brain injury now? Even stick as well.
You can have another stroke.
You can have another stroke.
In the next first 2 weeks, another stroke.
Okay, yeah, that could happen. So when you have an injury like this, the bit of brain that's damaged, that's kind of done. You can't do anything about that. You might get remodeling, you might get rehab further down the line, but the bit that's damaged, you can't really do a lot about that. One of the problems with brain injury is that the area around damage, you lose auto-regulation, so it becomes really, really dependent on that supply of blood and oxygen to it. And that bit's vulnerable, but you can salvage it, you can save it by ensuring that you get enough blood and oxygen to it. And that's really what secondary protection on neuroprotection is about. So the bit that's treatable to some extent, the penumbra, the area around an ischemic lesion or the area around it, you want to optimize the perfusion during that period where cerebral autoregulation is impacted. So when we're trying to neuroprotect someone, what sort of things do we try and do? I've said that we want to get enough blood and oxygen to there. So what sort of targets are we going to have in our physiological parameters?
65.
So you aim for a higher. So tend to assume that the intracranial pressure to raise, and it will be in someone who's had a brain injury. Assume that that's about 20. Your normal map is 65. So if you've got 65 minus 20, your sort of cerebral perfusion pressure, the amount of pressure pushing that blood up to the brain is quite low. So actually aim for a higher than that, aim for 80 to 90. So that sorts out your flow, but what about other things? We're trying to get oxygen there, so what else do we want to optimise? Losing what I've said.
Give them oxygen.
Give them oxygen. Yeah, so you aim for SATs and national guidance, SATs of 94% and above. So we've got some blood and oxygen into the brain. The other thing we probably want to do is to try and keep the pressure relatively normal. So there are any other things that we can do. CO2 normal. So we used to hyperventilate patients, bring their CO2 down. Why do we do that?
With the circulation in the brain.
Increase CO2 quantum breathing.
Okay, and what does that lead?
Increase cerebral blood flow and increases.
Yeah, well done. So for those of you, anyone online or here during the FRCA, they'll talk to you about Monroe Kelly doctrine, which is that the skull is a fixed box, and you have blood in there, you have brain in there, you have CSF in there. If the pressure goes up, something has to give. And actually, in hyperventilating, or at least keeping the CO2 normal, that just means that you reduce your caliber of the blood vessels and reduce that volume slightly. In someone that's a bit older with cerebral atrophy, there's a bit more room for the pressure to increase. In someone that's young, there's a bit less room. But what you don't want to do is to squish the brain down into the foramen magnum, tonsil herniation. So when you're undertaking neuroprotection, you want to aim for an adequate map, you want to aim for adequate oxygen, you want to aim for a low normal CO2. And those are the simple things that we do. So you'll have seen that we sit those patients up to increase venous drainage. We try and use sticky tape to hold the endotracheal tubing rather than tie around the neck. So you don't want to occlude the venous drainage of the head as well. And we used to cool people to reduce the cerebral oxygen consumption. We don't do that anymore because it makes people shiver. It paradoxically increases CO2 and it causes all kinds of other problems like glycophobia and acidosis and all kinds of things that you really don't want, especially if you've got a brain injury. So there's certain bits of that neuroprotection that we do, and you'll see that a lot on here. I popped a link on there to neuroprognostication. So neuroprognostication is essentially trying to read into your crystal ball and work out whether the patient's going to do well or not. Can we do it at this point? No. No. So there's guidance for devastating brain injury, which is an injury that you would perceive to give a significantly poor outcome, that we shouldn't be prognosticating at least for 72 hours. That's why you sometimes have someone with a scan that shows quite a lot of blood in the head or damage, that we say, well, after we don't know, the image is just the image, we have to wait and take down the sedation and see what happens. And we keep those patients for 72 hours afterwards. And I know there are, I don't think it's ever happened here, but there are some centres where that's happened, and a patient that's perhaps then gone on to have brainstem testing and they're found to not be brainstem dead, which, when you've had all those conversations with the family afterwards, it muddies the water and it affects that relationship with the family. Actually being clear about what you're doing, that there's nothing going to happen for 72 hours, that we're going to be giving the patient the best possible chance, but the outcome might be poor, but we just don't know at this stage. It's a useful thing to do at that point. So the best way of knowing is to take the sedation off, and that's exactly what we did. So day 2, the patient was off sedation and didn't have any response at all. So they weren't responding to stimulation. They were on the ventilator at that point because we were still neuroprognosticating. We were still trying to optimize their CO2 and their oxygenation, but they weren't having any other response. I know that Dave's going to show some images in his talk, but this is a slice of the CT, and I've just put a red circle around the hyperattenuation on the basilar artery. And if you haven't got any comparison images, but if you see that scan in relation to some of the other scans you see of perhaps older patients, there's not a lot. To me, it's my relatively untrained eye, there's not like there's a lot of space in there. And that's where we ask for our radiology colleagues to help. I'm not used to looking at young brains. So day 3 came, 72 hours, unresponsive observation, becoming a bit hemodynamically unstable. We're on a bit of noradrenaline to try and drive the pressure so that we could maintain that map of 90. Didn't appear to be breathing at that point. So, yeah, really poor joke. he dead or not dead? Hold on. He's not dead because you haven't tested for it, and his heart's still beating as well as we know. So he hasn't met the criteria for death. And so I mentioned there was guidance on prognostication after perceived devastating brain injury, and this is a paragraph there which essentially says that if you were to look at a scan that you thought was really, really terrible, there's potentially retrievable patients that you might, the wording is potentially retrievable patients and not mistakenly abandoned, which sounds a horrible way of putting it, but essentially if we're drawing on someone that does have some rehabilitation potential. And actually those people that have got a really bad injury are the ones that benefit most from really tight control of their CO2, their glucose, their oxygenation and their temperature, and they may well benefit from rehab. So if we were to withdraw really early on some people without going through the process, we might miss some people who have the ability to benefit to contribute to a meaningful life. And we don't know how long the optimal prognostication period is, but it's probably between 24 and 72 hours. For those of you doing exams, that's the company and neurologist consensus statement on neuroprognostication after perceived devastating brain injury. And the links there in the output. So what is death? I'll give you two definitions of death. So just remind me.
After the second observation.
Okay, so that's if we've gone on to neurological testing. So in that case, you're dead because you developed an irreversible apnea coma with irreversible loss of the capacity for consciousness. That's what we call death by neurological criteria. And that involves a bit of testing and is a bit more, it's not necessarily always obvious. Are there any other ways that you can die?
Death by, is it cardiovascular criteria? Yeah, where we normally diagnose death, like with wards and stuff.
Yeah. That's circulatory death. And bonus points, there's another way that you can die as well.
I don't know what it's called, but is it like when it's immediately obvious that someone's dead? So like go to an RTC and different parts of the body are at different areas.
Yes. So I need to look at who's on the meeting, but there is a consultant colleague or relatively recently moved on consultant colleague who had some experience in major trauma. And I remember sort of the stories of him going to an RTC and saying, well, that bit's dead, and that bit's dead, and that bit's dead. So that's the somatic criteria, and that's why there's been decapitation or putrefaction. So there are sort of three ways that you can die. So the two that we generally use in hospital are cardiovascular criteria or cardiac criteria, or respiratory, cardiac criteria or neurological criteria, and then the somatic criteria as well, which is the other one. I said that neurological criteria isn't always obvious, and it's the irreversible loss of the capacity for consciousness with coma. And there are a few things that can mimic that. So we said that you get someone coming in with drugs on board, they might mimic that. If you've got someone who had a massive fentanyl overdose, they're not going to breathe and they're not going to be awake. If you've got someone who's got a sky-high ammonia, they're going to be in a similar picture. You've got drugs intoxication and metabolic causes, but then you've got other causes. So you can have people with a sort of locked-in type syndrome who can't really respond to you, or who've got high spinal cord injury who also can't respond to you. And then I know recently we've had patients with Guillain-Barré or critical care acquired weakness who've been, to all intents and purposes, appears not to be doing anything because they can't move. So it's not always obvious, and that's the reason that we have to sometimes go on to test. And even then, it's still sometimes not obvious. And then we have to look for look at the perfusion, which is why we request the ancillary tests. So when we're testing a patient, I said some of the death mimics that can sometimes contribute. So stands the reason that we want to go and exclude any of those things. So we previously had what are called we had preconditions for testing, which is essentially that your electrolytes are within range, specifically things like magnesium, phosphate, potassium, sodium. I think very low sodium can cause you to be unconscious with it. You have to make sure that somebody's not on any drugs that will cause it. There are some specific questions on the testing sheet. And you have to be confident that there are no metabolic causes. So if you have someone with extremely high urea, you might be very cautious about whether you can test them or not. And if you can't test them, but you think they might be brain dead, then you might need to go on to do the ancillary testing we're going to talk about. Seems like a reasonable point to highlight some changes between the old and new guidance. So things like posterior fossa lesions in the old guidance were listed as red flags. So times when you might consider using additional tests. The new guidance has a whole list of preconditions, which are a specific part of the test that you have to satisfy before you can go on to go and do the test. So that brings us into line with the rest of Europe. When you're testing people, you've done your preconditions, so there's nothing that makes you think that they're unconscious for reasons other than their brain. You essentially do a structured cranial nerve examination. So you're wanting to confirm the absence of the cranial nerve reflexes. And those tests are done by two doctors, one of whom is a consultant, both of whom have been registered at least 5 years with the GMC. And in turn, you do those examinations of each of the cranial nerves. And then you do an apnea test. So I said right back at the beginning that death by neurological criteria was the irreversible loss of capacity for consciousness along with irreversible apnea. So you confirm that somebody doesn't have the ability to breathe. And essentially we do that by taking a patient off the ventilator. You have to be quite careful because if you see our patients on CPAP ASB, the ventilator will detect if they're trying to take a breath and it will do some more ventilation for you. If you've got a young fit person who has got a big sympathetic response because their brain's being squished, then the ventilator will sometimes pick up their cardiac oscillations and would, if they were on CPAP ASB, think they're breathing and try and breathe for them. So we take someone off the ventilator completely after a period of pre-oxygenation, uncover their abdomen, or put them on a green bag. And for the duration of the test, we watch the abdomen for signs that they're trying to breathe. We watch the CO2 trace, we watch the bag. And if we've got somebody that doesn't have any other significant injuries, their lungs are okay, you can survive being apneic for that period of time. And if the patient doesn't make any effort to breathe in that time, they have demonstrated that they have irreversible apnea. What do you think would happen to the blood gas if you did that to somebody? So you put them on 100% oxygen, you don't ventilate them. What changes would you expect to the pH, PO2 and PCO2? CO2 retention, okay. What happens to the pH? I think pH would reduce. Yeah, so yeah. What happens to PO2? And so usually on 100% oxygen, so the PO2 is actually often not your problem. If you've got someone that's really, really unstable, you sometimes end up with a desaturation and have to abandon the test before the time. So it's 5 minutes, but it can be longer because you have to demonstrate a specific rise in CO2 and a specific fall in pH. So you can keep the test running until you get that right and the patient doesn't desaturate.
So sorry, you end the apnea once you reach a certain PCO2, is that what you're saying?
Yeah. So you do a blood test before you start the test, and the reference range fall out of my head, but your CO2 has to be a level where someone is going to breathe but not too high before you start the test. And then you're looking for a given rise by the end of the test. That's another change between the old and new criteria. The final pH, sorry, final pH, PCO2, I think used to have to be above Used to have to be above 6, but it's now above 8. So it's the guidance has changed recently, but you have a significant rise in PCO2 where you would normally expect the patient to be able to breathe, but they haven't. If you do ancillary testing, where you can't do those things, but you still want to confirm neurological depth. So if you can't do a full CNS or apnea test, or if you think there are confounders, so a change with the new guidance, if you don't have 2 eyes and 2 ears, you can't test the vestibular reflex, or you can't test the pupils. You go on to do ancillary testing, which brings us into line with the rest of Europe. If you've got confounders like somebody who's been on sedative agents or perhaps got a high urea or high ammonia, you would need to go on to do ancillary testing as well. And ancillary testing is a specific sequence of radiological scans to demonstrate that there is no flow within specific regions of the brain, and Dave's going to talk to you about that shortly. But from our side, the test is requested in a specific way. So we'll be requesting a CT angiogram to support testing for brain stem death. And we'll be discussing that as a consultant from the radiology side to make sure the test is performed by the correct protocol. So this patient had a standard CT angiogram performed, but it wasn't done according to the guidance for how we should be doing the scans. So you have to demonstrate, my understanding, you have to demonstrate flow, that the brain would be capable of receiving flow, so there's flow to the appropriate parts of the carotid arteries, but there isn't flow within the brain or out of the brain. So it's looking at very specific parts of the brain. Unfortunately, the patient had contrast for that scan, so they couldn't go on to have the scan performed according to the correct protocol immediately. So we had to wait until the next day, after having a conversation with the family that we think your relative might unfortunately have died, but we need to do some further testing. Led to, I'm very, very sorry, but we need to do some more testing. The patient did have a valid scan performed the next day, which was consistent with brainstem death. And there's a specific phrase in the report that has to be there to support the testing. So brainstem death testing was completed, and the patient was confirmed death by neurological criteria. And this was under the old guidance. So it was so you'd normally use the time of the first set of tests because this was before the change, but actually this patient didn't. The patient needs ancillary testing. I will send these around. These are just links for people that are doing exams. But this is links to the new guidance. And in conclusion, the patient was on the organ donor register, so the donated kidney, lung, heart, bone, tendon, femoral vessels. Liver went to research. I spoke to the family to apologise because that fell under the duty of candour criteria because the patient was irradiated twice. And also from a humanitarian point of view, actually, we unfortunately ended up prolonging from the time to death and the time to then donate to the patient. So I did feel it was important to have that open and honest discussion, which we did. So in summary, neurological death is loss of brainstem function and apnea. According to the new guidance, you can only do the testing if the criteria are met. So you haven't got any confounders like other drugs or metabolic causes, and you can examine both eyes and ears. Beware of death in the mix. So if you've got a big posterior circulation stroke, you'd be really worried about just going on clinical grounds. If there's doubts, firstly, one of us as ICU consultants would be involved anyway, but definitely talk to us, and we'd probably be talking to radiology about ancillary testing if we're not sure. It's one of the things that you only essentially get one chance at, because the aim is to really give the family as good a death as possible. And if you haven't, it's worth reading the 2025 guidance because that's what we have to use from here on in. So that's just going to stop sharing. So that's all I had to talk about So does anybody in the room or online have any questions or you'd like to ask me?
To say as well, this case is obviously referred to the coroner. It was a restricted donation, so the coroner said nothing above the head because that's where your problem is. But this is all weekend, so we had access to this. We obviously couldn't do for years, but everything below the neck was we were able to do.
That's a really good point, Steph. Actually, when we have cases of deaths where there may be a need to examine the body, that would normally fit our criteria for coronial referral. So unless the coroner is quite pro organ donation, and if there is the ability to do restricted donation, they will usually try and facilitate it. But if it's a death where we would normally have to refer to the coroner, we do have to ask them for permission in order to do that. But that shouldn't stop us. And the national guidance is actually we should give the opportunity to donate. So we should be having conversations with support from our specialist nurses as well. Any other questions?
I know you said with the 2 ears, 2 eyes. What about with hair? Like older people generally have like hearing loss. How much ear do you have to have?
So you have to have there has to be a sort of orifice there. So that part of the test, you're not testing someone's hearing as such, you're testing their vestibulocochlear reflex. So that involves putting 50 ml of ice cold water into their ear. You have to make sure you can see the eardrum. You have a look and do a bit of de-waxing if you need to. And then you usually end up with nystagmus. It's pretty unpleasant. And if you were conscious and awake, you'd be very sick if we tried to do that to you. But the point being, it has to be a very potent stimulus. And if that absence of reflux is absent, that's what we're looking for in this test.
So because it's not hearing pathway, it's still.
Yeah.
If you don't got somebody with one ear or one eye, or you find they've got a false eye, you'd have to do something to like treat your cornea.
Okay. So because this was a bit of a combined case and we wanted to make sure that we had fully met the criteria and we had to request radiology support in the test. It doesn't come along very frequently for us, which is why I wanted to cover it. And it's part of the radiology curriculum as well, so I wanted to do a bit of a combined day. I think David is going to show us some images and talk about, when we request one of these tests, what happens from the radiology side. Because we generally don't sort of see that.
Yeah, hi, it's Cindy. Just not so much a comment as a plea, really, to try and, I mean, you've basically said it already, Chris, but I know that there is always pressure on beds, especially at the LRI. But if we could facilitate the admission of patients with devastating brain injury to ITU for prognostication, we would be extremely grateful. Our numbers for organ donation, especially death by neurological criteria, have dwindled significantly, and that is in part due to patients being palliated in A&E because they're not being admitted to the unit for prognostication. So if there is any opportunity to admit any of these patients to the unit for prognostication and consideration, obviously that would be really helpful.
Really good point. Thank you, Cindy. So we should be offering patients and their relatives the opportunity to do this according to national guidance, and I know we try and facilitate where we can. Thank you.
Well, devastating brain injury guidelines as well. Sometimes comes up in exams too.
Yeah, I've got some links on the talk. I'll pop them in the chat later because it's certainly if you're doing exams, they're topical and relevant. And given that we've just had a revision of some of the guidance, it's probably a surefire thing for an exam fairly soon.
My name is David Swinton. I'm one of the neuroradiologists here in Leicester, and I'm in fact the group lead for neuroradiology here. And just picking up on something that was said earlier was the reason I'm here and this discussion happened was around people not being aware of some of the up-to-date criteria. And again, so I trained in QMC where Rob Deneen is, and obviously Rob Deneen is one of the names on a lot of the guidance here, and I just assumed that everybody knew this, but actually it had been part of my training. So by way of my credentials, really, I learned my trade in this from Rob Deneen, who is more or less the national lead on this. I was going to jump in. I mean, the guideline that is really relevant here, and very much supports the new Royal College's guidance, is this 2023 consensus guidance, and this was, involved neuroradiologists, from the beginning. It started with Dale Gardner speaking to Rob Deneen at QMC years ago, and sort of talking about how they could progress CTA. These guidelines are fantastic, and I'm going to try not to reproduce them too much, but I'd encourage you, if you have an interest, to go and read these. They're incredibly short, they're incredibly concise, and from a radiology point of view, they're an absolute dream. I know we're drowning in guidelines, but these are absolutely perfect from my point of view. And the role of the radiologist is clearly involved, and it's made very clear in what we have to do. I think the take-home point is that the scans themselves are not particularly complicated. So plain CT head, CT angiography, those are not complicated studies, particularly for a neuroradiologist. But there are little finicky things to follow. There are little things that have to be done just right. And there is some tolerance in there, but obviously you don't want to deviate too far from a recommended protocol, particularly if you're dealing with consensus and obviously the subject matter. And there are some reporting standards as well, which I think are really useful. I generally don't like stock reports and tick box reports, but in this case, I think it's very useful to be clear and unambiguous. So why have we gone for CTA? I really think, availability and familiarity with the study are important. There are other proposed tests. CTA is not widely accepted, and it's available outside neuroscience centres. And I think it's really important to remember that whenever there are guidelines being set, having attended guideline setting and gone down to London, and everybody assumes you can have a whole body MRI, that afternoon, because that's what they can get in UCL or whatever. You have to remember what's actually going on in most of the country, and CTA is good from that point of view. It's readily available. It's reproducible, and I think the guidance around how the scan should be performed is very important, because what it is doing is ensuring that this test is as close as we can make it in each person having it. And scanners obviously vary. Same scanner, same brand of scanner in the same department producing different images, and obviously different brands will produce different kinds of image, but we're trying to control as much as possible, and there are some technical factors in there that aim to do that. Estimates of sensitivity are sort of in the 70s to 90%, depending on the study you look at. Specificity is interesting, and it's generally given at 100%, but there really are small numbers. But the thinking is that you want a very specific test, and the sensitivity can drop a bit, because you don't want the situation where you have a false positive. You don't want somebody who isn't brain dead having a test that suggests they are, and a specific test will mitigate against that. Of course, calculating that is quite difficult, because actually how many people who aren't brain dead are we sending for ancillary testing in the formal way? I mean, you could argue we're sending hundreds of thousands, for CT angiogram every day, and people who aren't brain dead. And there's some reporting criteria, and those are really good for reducing inter-observer variability, and they're very straightforward, and the criteria we use in the UK for the UK consensus are very clear. So that is good, because that leads to I dare say some radiology reports are less useful than others. So who and when? So again, this is directly from the criteria, the consensus guidance, the 2023 guidance, and that talks about when you can't complete the testing, or there are confounders, so extensive facial injuries, high spinal cord injury, concerns about residual sedation, so overdoses, metabolic and pharmacological derangements, decompressive craniectomy, not so much of an issue here, but in some centres, a lot of decompressive craniectomies can cause problems. And the ones I put in bold are the ones we have had testing for at UHL that I'm aware of, so high spinal cord injury and concerns over lingering sedation. I think that the case that was covered earlier is sort of in between. I think it's maybe slightly compassionate, but also again, there was some of the testing was simply to make sure it was done to the correct protocol. It's not particularly common. So of the cases I have, I'm going to show you 2, and the third one you saw earlier. So that's 3, and this is going back probably about 5 years. So it's not a very common investigation at all. And that brings its own problems, regardless of how straightforward it is. So what do you need to do? You need to speak to a neuroradiologist and a neuroradiology consultant. And we have a plentiful supply of those at UHL. So please do find one. The first port of call would probably be the imaging hub. I'm afraid you might have to, bear with the 16969 number, but speak to a neuroradiologist. Because essentially the CTA is the test you're asking for, and it needs to be done in a very particular way. And the consensus guidance specifically says this is a consultant discussion, and it should be made explicit that this is testing to supporting diagnosis of death. And that CTA should be reported by a consultant, not given as a provisional report, provisional registrar report, and then looked at later, because obviously the risk there for a provisional report then being corrected is unacceptable. And not an issue here, but potentially if you're in a centre without a neuroradiologist, they may wish to speak to a local neuroradiology colleague, and certainly speaking to colleagues in centres with varying degrees of neuroradiology support. They may do that, or they may simply report together, so have 2 radiologists reporting that. And in fact, some centres will issue a dual report. You have 2 radiologists look at it. It really does vary. That's not the practice here. I think we're able to look at these in isolation. So I'm going to look at some. I'm going to look at some scrollable images, because I think that's the best way to look at these. But I just want to cover what a CT angiogram is from the very basics, really. So you perform a CT head. So that's what you have there, the image on the upper left. But you do that CT head after you've injected some iodinated contrast, and the iodine in that contrast agent absorbs X-rays very well compared to tissues. So CT is a very good investigation for demonstrating contrast between soft tissues, and you can enhance the radiographic contrast. That is to say, how bright and dark different tissues appear by giving something that contains iodine. So if you look at the middle cerebral arteries on the top image, you can see that you can see them, but they look very similar, sort of greyness, attenuation to the rest of the brain. But after contrast, you can see they light up like a light bulb. So you'd say on CT they're very high attenuation, or they're very dense. And again, it's a very common investigation. We do them all the time, particularly with the mechanical thrombectomy and stroke services. We're doing plenty of these every day. It's something people are familiar with, and importantly, our radiographers are familiar with, and they're quite often forgotten, our radiographic staff, because it's one thing to ask for these tests, and it's one thing to say yes and look at them, but in between there is the very important step of someone actually doing them properly and working the working the very large expensive machine that churns these out. They don't just appear. So we're indebted to our radiographic colleagues for generating these and getting them right. So the guidance is very specific and very good at about what should happen when we scan these patients. So the patient needs green cannula or bigger, and just before scanning, they need to have a mean arterial pressure above 60 millimeters of mercury, and that should be documented. So from our point of view, that is something we would like you to do, as the patient is coming down, before they come down, and just before scanning. So that needs to be done, otherwise this scan has not been done in accordance with the consensus process. You then do 3 very similar acquisitions or scans. So you start at the C2 vertebral level and scan to the convexity at the top of the head. So the first scan is just a straightforward plain scan. You do that before the injection of contrast. There's then some specifications about the nature of the contrast, how much you give. 120 mils is actually more than we give for a lot of our intracranial angiograms. So again, this is why this has to be discussed, and the protocol has to be made clear before the patient comes down. A particular strength of contrast has to be used. We then do a second scan, and that is done 20 seconds after you start to inject the contrast. And so there are different ways of timing angiographic studies, but this is done purely on a timing protocol. And I think the reason for that is just to make sure each scan is done exactly the same. Now, of course, there will be variability there, the cardiac outputs and so forth, but by performing these to exactly the same protocol each time, you're looking for a consistency there. So that's why they do it. And then as the third scan happens, 60 seconds after the beginning of contrast, so 40 seconds after the previous scan. And again, I'll go into what those show. And then there are some very technical bits and pieces about the slice thickness, the kilovoltage peak of the machine, the field of view, and the matrix display. But also importantly, the images need to be labelled as to whether they were pre-injection 20-second or 60-second runs. And again, that's something that will not happen unless radiographers have been primed and things have been discussed beforehand. So none of this is particularly, it looks complicated, but none of it is particularly out of the ordinary, but there are just little idiosyncratic bits and pieces that need doing to make it compliant. So the interpretation, why are we doing those 3 scans? So the first scan, the plain scan, is effectively a control. And that control is useful because what it allows you to do is to look for anything that might be high attenuation or bright before you've even started. And I'm going to show you some imaging. And when people have got very advanced hypoxic ischemic injury, you get all sorts of things in the head that are meant to be there that look incredibly bright. And that's just simply because they've got very swollen, edematous, dark brain up against them. And for a mixture of reasons, some of it is artifact or sort of almost optical illusion, really, that can make normal structures look brighter. And you can then discount those later on in the imaging, because effectively what you're looking for is in a pacification of vessels or high attenuation on the subsequent imaging. So the second scan, so the first scan once you've given contrast, the reason for that is to make sure the contrast has actually gone into the vein, it hasn't extravasated or gone anywhere else, I don't know where, but you need to make sure it has gone in, it has gone into the intravascular compartment and it's arterial. And you're looking at the temporal arteries, effectively branches of the external carotid, to make sure that contrast has gone where you want it to and has reached the level of the brain. So again, that's the role of the second scan. It's essentially sort of a control to say the contrast has gone in. The third scan, done at 60 seconds, is the scan on which you do the assessment for a pacification of intracranial vasculature. And the protocol that has been by consensus arrived at is using this four vessel protocol. So you look at the distal cortical segments of the middle cerebral arteries at the left and the right, and you look at the left and right internal cerebral veins, and each one of those is given a point out of 4. If you have a pacification of any single one of those, you cannot support the diagnosis of death with neurological criteria. And again, some of the terminology is odd, but a positive scan is one where there is no flow, and that would support brain death. So just saying that that's what a positive test is in this situation. So a negative test would be one where some degree of opacification in those vessels is seen and it can't support. So this is from the original, the Frampas paper, which the protocol has been based on. And this first imaging is just showing these arrows here are highlighting the superficial temporal artery branches that are opacified. And this is some normal internal cerebral veins. So they're very central. Again, you're not probably used to looking for these. They very rarely come up unless they're thrombosed, which is relatively rare. And the normal cortical arteries, you're looking right out at the edges into the sulci for these normal cortical arteries. These images are from Rob Dineen's sort of comment paper in ClinRad, which he and others made after the consensus guidance came out, but really showing what you might expect to see in a plain 20-second and 60-second study. So you can see that on the plain study, you do get some high attenuation, and in some areas where it might cause confounding interpretation of the internal cerebral veins. But so on the pre, you can see this is a very hypoxic looking brain, very swollen. There's no grey white matter differentiation. On the 20 seconds, you've got the opacification of these arteries. And on the 60 seconds, that confirms it's you're good to go to the next study and continue interpretation. There is no opacification of the cortical branches, and the internal cerebral veins are completely unfilled as well. So that would be a positive study supporting brain death by neurological criteria. Are there any questions so far? So I've rattled through that.
It's very subtle change to the non-expert eye. It's quite subtle.
It might just be, I don't know what you're watching on. It might just be the fact that those are kind of screen grabs of JPEGs from PDFs and things. I've got some diagnostic imaging. It might be less subtle, but it can be, and you have to know what you're looking for. And I think this is why it's important. It's all done.
Thank you.
Really, yeah. I think it's not. Radiology is a great one for having a go, and it's fine. But it's easy enough to kind of look at the bit you're looking for. But then we all say this to the stroke team. Some poor person has to go around afterwards and make sure the neck isn't broken, there isn't any funny tumour or anything like that, and the lung apices and things like that. But that's the job we have. Right. So let me try and share these images. So I'm going to show you some normal first. So this is not a patient with brain death or anything like that. So this is a 59-year-old man, and I just pulled him off the day list. He is for mechanical thrombectomy, and the reason I've taken a mechanical thrombectomy scan is because we do a plain scan, an arteriogram, and a CTV, which is not a million miles from the brain death protocol, but critically is not the same. So I'm just going to go through some bits I heard, and I think it's true. Talking about things like grey white matter differentiation loss, those are what I'd call findings, and they're important to recognise, and they go into radiology reports. But I think in a conclusion, somebody should say what they mean by that. And very much the body of the radiology report, it can be read, but it's quite often I feel that's how kind of radiologists communicate with each other. But in the conclusion, you want somebody to say the grey white matter differentiation loss equals an infarct, and it's due to this. rather than just leaving sort of the findings bare in the conclusion. So coming through, so I completely agree, and I think some of our colleagues early in their career as registrars struggle with this, which is, yeah, we're used to looking at 80-year-olds on a Pixaban who have fallen over. That's every case from A&E. And we don't often see the kind of 20-year-old, there's nothing wrong with them. So, you know, maybe the kind of, I call them the kind of drunk fighting men that seem to come in on Friday and Saturday. They're maybe the younger brains we see. But this is a 59-year-old man. You see, he's got plenty of sulcation. I think he's got too much. I don't know what's going on, but he's a good example of how, you know, how much sulcation you have. So even at the top of the brain, even in a young person in their kind of 20s, you should have some sulcation at the vertex. So this is his plain scan, and it really just to go over what a normal brain looks like. I think it's been atrophied, but we'll leave that. There's some loss of grey white matter differentiation. He was a stroke. He's a mechanical thrombectomy scan. So what you have here is a cytotoxic edema. Water goes into the cells, and that evens out the normal status of things, which is where the grey matter is slightly brighter than the white matter, because the white matter is full of myelin, which is fat, which is very low attenuation on CT. If you look at the fat in the scalp, it's very low attenuation. So that's why the white matter is a bit darker than the grey matter on CT. It's a bit fattier. But once those cells have died, the water starts going in. The attenuation of both goes down, and they tend to even out. So that's what loss of grey white matter differentiation is. People shouldn't really use that term unless they mean infarction. I think any other use would be leading people astray. And so you can see the grey matter slightly brighter. You've got the thalamus slightly brighter. These are the deeper grey matter structures, and then the basal ganglia, so the caudate, the lentiform. So these are normally a bit brighter on CT. And just going back to what does a hyperdense vessel mean? Again, people shouldn't be saying the word hyperdense vessel really, unless what they mean is there's a clot in this vessel. So this chap had a stroke, and it's very, very subtle. But here's his middle cerebral artery. Can you see it's got this sort of brighter bits? And again, I appreciate it might be it's a bit subtle on this one. This is a subtle one. You know, if I wanted to pull out a dense vessel, I probably would have found a better one. But he just happens to have one, and it links to the first case. So a hyperdense vessel suggests clotted blood, and again in the context of stroke would be relevant. So that's a sort of plain CT head and what it looks like. This chap would want to have a CTA, and again, so a normal CTA, we don't normally do the neck, but we do a mechanical thrombectomy. So you can see now it's got some contrast on board, and this is the common carotid artery bifurcating into the external and the internal carotid, and you can follow those up now. You can see these beautifully, the internal carotid arteries coming up and through, and then terminating as the middle cerebral arteries and the anterior cerebral arteries. So this is just to show the power of CTA. You know, you're really, really nice contrast between the vessels and the rest of the brain. You do lose a bit of brain differentiation, but that's part of the price you pay for having such good vasculature, the contrast. So there's CTA. So what are you looking for in the brain death studies? The opacification of the external carotid arteries. So you're looking for these out really. The temporal arteries are the ones that are used, and you can see those, you know, well opacified. Obviously, this person doesn't have raised intracranial pressure, so you're seeing very nice intracranial opacification as well. Even on this relatively early stage, you can see the internal cerebral veins. So here they are. These kind of paired structures sitting really just above the third ventricle, and again they're paired. They then go back and join and flow into the straight sinus, and then into the transverse sinuses. And you can see that the stage we haven't got much contrast in the distal parts of the transverse sinuses, and that's because the timing isn't there. But if we use the CTV now, was taken on a bit later, you can see how beautifully opacified those transverse sinuses are, and you can see your internal cerebral veins again. And what you see now is these larger vessels are actually veins. So this isn't the superficial temporal branches. So again, you have to be careful with what you're looking at and how you interpret it, and following things back and forth. So that's a normal from a kind of brain death point of view. Obviously, he had a stroke, but it was a useful example because of the similar phases of the study. So if we go back to our case presentation, so the first case I'm going to show was a 25-year-old woman who there was an attempted hanging, had a cardiac arrest, 15 to 20 minutes, ALS resulting in return of circulation, GCS of 3, intubated and ventilated, and had a CT head on day 1, which had some early hypoxic ischemic injury, although there was limited edema and certainly no coning, or cerebellar tonsillar descent, as it's sometimes called. Went on to have an MRI, which showed frank hypoxic ischemia injury and coning, and also confirmed the cervical cord injury at C23. And because of those features, she went on to have the protocol we now recognise from the consensus guidance, but this was actually before then, and we used the FRAMPAS protocol because that's what I'd been trained to use, and it was me the case was discussed with. Although that did become the basis for the current guidance for reasons I've discussed with Rob Deneen, sort of developing this at Queen's. And actually it was done prior to brainstem testing in this case. Was the CT head on presentation. Again, it can be quite difficult to look at, sort of funny angles, an ET tube. But as you scroll through, she's 25, and you get the impression that even with that funny scan angle, you just can't see the grey white matter differentiation as you ought to. And coming up to the top of the brain, there's a bit of sulcation, so maybe that's normal for 25. There is a bit of variability here, but it's very hard to appreciate some of those deep grey structures. But if that scan report is normal, so be it. There's a very leading history. Somebody with a prolonged downtime who has a scan, I mean, you have a fairly low threshold for hypoxic ischemic injury, but equally the scans can be noisy and quite difficult to interpret. So it's not uncommon to have these reported as no abnormality demonstrated. I just want to show you her MRI cervical spine, which I know is a bit off piece, but it shows a few interesting changes. So this is an axial T2. This is the C2 vertebral level. So there's some abnormal signal within the cord there. So that's a direct result of the trauma, the attempted hanging. And what you can see here is this is the tip of the clivus, which is the kind of front end of the foramen magnum, and there's the back of it. You can see the cerebellar tonsils here go all the way down. They're almost at, they're at the level of C2. So this is cerebellar tonsillar descent or coning. Clearly, your cerebellar tonsil shouldn't be there. So again, this is the direct result of pressure. And once you've seen that, it's you can be fairly certain there's fairly significant raised intracranial pressure. And her brain CT. So we'll start by looking at the pre. So again, it's nicely lined up now because she's intubated and ventilated. But so coming up immediately, you can see the foramen magnum is full. There's the spinal cord anteriorly. There's some vascular structures and dura there, but behind it, that's cerebellar tonsils that are sticking through the foramen magnum. It's completely filled. And as you scroll up, you just see there's absolutely, this is a very dead looking brain. So completely bland. There is no grey white matter differentiation. You can't point to any of those deep structures. There is absolutely no sulcation. All the way to the vertex, it's completely filled. So this is frank hypoxic ischemic injury. So these are the sorts of reports you read, diffuse loss of grey white matter differentiation, cerebellar tonsillar descent, those sorts of things. But it's important because you start to see all these normal dural structures. So this is the falx cerebri, and this is the interhemispheric falx. They all look quite bright, and they normally look like that. It's just they don't look quite that bright because they haven't got edematous brain right up against them. So it's an important study for establishing what the state of play is before you've given any contrast. And you get the impression is, I'm really struggling to show it, but really hard to see any normal ventricles. And again, they're being compressed by the raised intracranial pressure. So when you see this sort of appearance, you can be fairly confident as to what's going to be on the CTA. So we actually did her neck because on the CTA because of the cervical injury, but I'm going to just scroll through that. So this is the 20-second study, and you can see beautifully these branches of the external carotid artery light up. So from a technical point of view, this is good. We know contrast has gone in. It's interarterial. It's the right sort of phase, and it's up to the level of the brain. So that's what we want from the 20-second study. You then move on to the 60-second study, which was a bit noisier in this case. And again, that was a technical issue. But what you can see now is you can see these much larger vessels in the scalp. So this is the venous, phase, and so that's tells you a story, doesn't it? That clearly things are fine extracranially. But this is the study where you're looking to see if there's any opacification of the middle cerebral artery cortical branches, and you can just see, I think, the carotid bifurcation here. But there's absolutely no contrast. It hasn't even got to the petrous portions of the internal carotid arteries. There is absolutely nothing. There's cerebral silence here. There is no flow. We don't use the word perfusion. This is not a test for perfusion. This is simply a test to say whether blood with contrast in it has managed to flow into those vessels. So you're looking here for the cortical branches of the CT angiogram. There's absolutely nothing, and the CTV, the internal cerebral veins, there's absolutely nothing there. So this is a positive scan. So left and right cortical branches, internal cerebral veins, absolutely nothing. So this would be a positive scan that would support the neurological diagnosis. So the second case, I won't bring up the slides just because there's very little to it. It was a 51-year-old woman with a mixed overdose with a cardiac arrest and a downtime of 27 minutes and was intubated and ventilated, and had a similar story. So her initial CT head she was actually a patient who previously had a intracranial coiling. So there's a streak artifact from a platinum coil. So they can be quite hard to miss. Again, she's not. I think her initial scan was reported as normal, although I think there are some subtle signs of hypoxic ischemic injury. Caudate heads, I can't see them as much as I'd like to. So that was her initial scan. It was reported as normal, but there probably were some subtle signs of hypoxic encephalopathy, but I would say subtle. Again, quite a hard scan to interpret. And because of the concerns about ongoing effects of mixed overdose, she went on to have the protocol as an ancillary test. So similar picture to the last one. Again, the ones you do see were not a craniectomy center, so you typically see the same thing. So diffuse loss of grey white matter differentiation. She's 51, but you should still have some sulcation, and the very first case I showed you was a 56-year-old, albeit one with, I think, a bit too much atrophy, but you should have some sulcation. No sulcation, no grey white matter differentiation, ventricles are small. You can't discern any of those central grey matter structures. But again, it's really important to have this pre, because you want to be sure you're not seeing any of these structures as dense, because you've misinterpreted pre-existing density. So that was her control scan. Then she went on to have, she had both sets of imaging sort of one after the other, which was slightly unusual, but it's what they did. So here the 22nd sequence images, and you can see you've got that opacification of the external carotid branches, which is what you want. That's good. That confirms that it's technically the contrast has gone in, it's in the right place, and you can proceed to the next phase of contrast to interpret the lack of intracranial opacification. She's got a bit more opacification of the carotids distally, but not much. So you can actually see them here. And on the left, you can see that, in fact, there's some contrast making its way. It nearly gets beyond the dura, but not quite. So as you pierce the dura, this becomes the terminal carotid, and the middle cerebral artery, there's no opacification. Again, we don't do many of these, but thankfully I've not encountered one where we've got contrast that goes much beyond the intracranial components, so you can be pretty certain. And again, looking at the M4, these cortical regions, there's absolutely no suggestion of opacification there. And then scrolling down to the ICVs, absolutely nothing. So again, this was another test that was pretty unequivocally supportive of brain death. So those are the two cases we've got, more or less out of the three that I'm aware of. So I said not a particularly common investigation. I'll just finish by saying, so CTA and neuroradiologists are, believe it or not, readily available at UHL. The most important thing to do is to speak to one of us. Be clear that what you're asking for is an ancillary test, and you should get the right scan and the correct report to follow. And just please be aware, although it's not a technically challenging operation, they're quite infrequent and have got specific technical requirements. So you can take something fairly straightforward, and if you don't do it very often, there's obviously rooms there for unfamiliarity and error. So it's always worth being very explicit and clear, making sure everyone's sort of singing off the same hymn sheet before you start, and it should go to plan. But thank you. If anyone's got any questions, I'm happy to take them.
Wondering, do you anticipate that this will be used more frequently going forward with the new guidelines? Is this something we're going to do more of?
I don't know, and it very much, I think it depends on you. There was a symposium at the end of last year at Nottingham, sort of talking about the anticipated change in the associated Royal College's guidance. I mean, that document's been out since January 23, and we haven't seen a flurry. It's really interesting. Even on the table I was sitting on, there was disagreement as to how often this should be done, when it should be done. Do you do it before or after your second set of brain stem testing? Do you do it before the first? Craniectomy was a big issue, but not a huge deal here, thankfully. But there were some centres that seemed to have formalised it to a point where it was being ordered in the ward round in the morning, and I think they'd formalised it there. I worry about making this too much like ordering a pizza, that if you end up with something like this going into becoming part of the protocol and sort of just getting the test because that's what the protocol suggests. I just worry that you end up potentially doing things we're not thinking about them properly. And it's got a sensitivity and specificity. I don't quite know how you calculate the specificity properly with this and the error around it. It needs to be on a case-by-case basis, and like every imaging investigation, it's part of a puzzle, it's part of the answer. It's very rarely the complete answer. So I think just be careful making it sort of a box to tick before something's done, because quite often, spending a lot of my time, in reporting scans for ED, where we're just at the end of a set of NICE criteria, and in reality, the usefulness of that test is in some cases debatable. I don't think this is a case where this needs to happen. I think it's too serious and warrants sort of discussion on a case-by-case basis.
I think a few years ago they did testing after a decompressive craniectomy and had to reverse the diagnosis. So following that, they then didn't test because it was a red flag that you don't test after that. Now they've added in PTA again. Actually, what they're finding is they can use that as evidence that they can carry on and do the testing. So like at Queen's, they will often, if they've had a decompressive craniectomy, then do a CTA, then do the testing, whereas they couldn't have done that in the last few years. So that's the biggest, I think the biggest thing that you'll find here is when it's not really eyes and ears, when you can't do the apnea test, if they're on a high PEEP or high oxygen. If you can do the rest, you might then do a CTA to confirm death, but not actually do the apnea test. That is very, very rare that you would ever consider doing that.
I've had a young lady taken a drug over quite a high patient, and that was another situation where we weren't clinically sure that enough time had passed for all the drugs to come out of the system. I mean, we waited weeks and weeks and months, didn't we? And this would have been really useful for her actually, because we could have demonstrated no flow.
Absolutely.
And it would have then helped us make a diagnosis of neurological death more safely. But the drugs that she'd taken were so lipid soluble, and she was such a large person, and she had such warping doses that actually the poisons team were like, wait 6 months. Like,
and in children, you can't do CTAs under 2. So the testing has to be 24 hours apart rather than back to back, because you can't do your CTA to confirm.
Okay, thank you very much, David. Thank you, everybody. So that was just sort of hopefully a bit of a recap about the change to the guidance, and within that we discussed a clinical case, and David's kindly given up his time to show some images, show what happens when we request testing or ancillary testing to support the diagnosis of brainstem death from the radiology side. Does anybody have any questions? We've also got Steph here, who's our specialist nurse for organ donation, who might be able to help with some specifics around the new guidance or specifics that you're not clear about today. And also, Dr. Whitman has put up the feedback link as well, which I think is in the chat too for those that are joining online.